Ladies and gentlemen, thank you so much for joining the professor and my platform on YouTube. As you know, this is a channel that brings you information that you can actually use, information that could make your life better. Today, it's a pleasure for me to receive Dr. Daniel Faustin, who is a gynecologist and a specialist in maternal fetal medicine. Just by way of introduction, Dr. Faustin graduated from the University of Brussels in Belgium in 1976 and did all of his training as a young doctor in the United States. He's also written many peer-reviewed articles, a lot of them, but he's also well known for the books that he has published. He published a new book titled The Secret of Life Before Birth. If you're about to have a child, you're pregnant, you want to have a child, this is a book that you want to read, but this will be the subject for another interview. So today we're going to talk about fibroid in the mature women. Dr. Faustin has been kind enough to make time for us to talk about that. Dr. Faustin, thank you so much for joining the professor. It's a pleasure to have you.
Thank you for having me. Thank you, and good day to your audience. And today, as you said, the topic that I'd like to talk about is fibroid uterus and pregnancy. Obviously, the pregnancy is a normal phase, so to say, of a woman's life. And in order for the process to be uncomplicated, there are a number of things that have to be in place for that to happen. Normally, we think of the uterus as a space in which the embryo and fetus develop progressively during a pregnancy. And it is clear that if there is any abnormality of the organ itself, it may interfere with the normal physiologic process of pregnancy. So fibroids, this entity, which is really a tumor, a benign tumor of the uterus, it arises, it comes into the muscle of the uterus, which is the wall of the organ. And as such, it grows from small to sometimes very large. One woman may have one fibroid growth, one fibroid tumor, but there are instances where the number can be many more. We're talking about over 20 single tumors that are present, and it is clear that they would interfere with normal life quite often. Fibroids in general, at the beginning, may be totally asymptomatic. There is no sign that would tell the woman that there is something that is developing into the uterus until she would go to her physician, gynecologist, for a checkup, and that would be a finding. Many times it's just taken by surprise. And again, if one considers the uterus as the organ that it is, from the cervix up to the fundus, which is from the lower part of it to the top part where the tubes are connected to the uterus, the fallopian tube that is, there can be fibroid disseminated all throughout. Some patient may have one, As I said before, others, they may have more than 20. It can be associated with menstrual abnormalities, usually heavy menses or prolonged menses. This can happen as a result of the irregularity that the fibroid size will cause into the muscle and the surface, the inner surface of the uterus, causing the lining to be uneven and irregular and larger, so there is more blood to come from it every time that there is a menstrual cycle, a menstrual flow. So again, it could be anywhere in the uterus. It could be inside the cavity. Okay, it could be within the muscle. It could be exterior to the muscle and connected to the uterus. Nevertheless, so issues with pregnancies would certainly come in terms of whether pregnancy is easy to take place when someone is dealing with fibroid. There certainly can be some challenges depending on where they're located. Clearly, if the fallopian tube, the access of the fallopian tube to the uterine cavity is blocked by a fibroid in that area, and that can cause infertility. There certainly there can be.
Let me ask you a quick question.
Yes.
Does that cause infertility in the way we know infertility, or it make it harder for the woman to get pregnant? Because I had my first wife had fibroid, and you know, we were married for a while. She couldn't have a child. We went to the doctor, surgery. They removed the fibroid. And then the doctor said, look, in the next 6 weeks, you got to get her pregnant because otherwise the fibroid can come back. But she did get pregnant, and my oldest son was born. This is back in 2004. When you said infertility, I'm talking about whether that infertility in the way we know infertility or a cause that prevent, that somehow make the pregnancy harder.
Oh, fine. But, you know, the infertility is not necessarily absolute or you know, untreatable. So there is a very good chance that in the scenario that you described, there could have been a temporary difficulty for the process of conception to take place because of that. And there is a good chance that the steps that were taken have lifted up the issue of prevention of the easy transport of the ovum or the semen into places where they can meet together in the tube. So, or even if there was a conception and the tiny little early zygote and embryo would have difficulties to pass through and implant itself into the cavity of the uterus. So yeah, I mean, it's not that it was a sentence of impossibility, but difficulty, and this is the whole role of the reproductive endocrinologist and infertility specialist, is to resolve the infertility issue, and so that pregnancy can take place. And I'm very happy that you were able to enjoy a happy ending in your particular case. And I'm sure many other viewers may share with you this kind of experience. So given the difficulties that we talked about, women with fibroids, they're concerned about whether when they're ready for the experience of pregnancy, it's going to happen right away. So certainly I would refer anyone to their physicians to work together with the practitioner in order to make it as timely as possible. So in terms of what that can do, let's assume there is a pregnancy that has taken place, and in the presence of multiple fibroids. The question one may ask is, do I have to be concerned about anything? Well, let's start from the beginning.
Mm-hmm.
In the first trimester, assuming you have implantation of an early embryo and it's developing, the risk of miscarriage is somewhat increased in association with fibroid. Because when you think of the implantation and the attachment of the early embryo to the wall of the uterus, if that wall is irregular, there is a very good chance that the presence of the fibroid can interfere with that process of development. And if the attachment is faulty, there can be bleeding that takes place, separation from the mother's womb, and that can lead to a miscarriage per se. But I would, if someone who's listening to this program were to be facing an issue of early pregnancy with fibroid and bleeding, it doesn't necessarily mean that that particular pregnancy is doomed to fail. It could be just a matter of difficulties to attach. Well, now, if the attachment may not be perfect to the uterine wall in one area, another area may be fine. So that if there is enough of the conceptus which is attached to the uterus, it may mean that you need to rest, take it easy, avoid the physical exercise, and things will come into place, and you can continue the pregnancy, and there should not be any problem. Now, the issue of the continuation of pregnancy, one may wonder, do I have any risk to be anything to be concerned about? If I don't have a miscarriage, does that mean that the rest of the pregnancy will be without any concern at all? And clearly that's not necessarily the truth, and one needs to be continuing a close observation to ensure that the fetus is growing appropriately. And that means we have at our disposal ultrasonography, through which not only the picture of the fetus can be taken, but also looking at the anatomy, looking at the inner organs, whether we're talking about the brain, the heart, the stomach, the kidneys, the bladder, extremities. All this can be looked at to ensure that the fetus is doing well. Later on, the possibility of looking at the fetal heart, the fetal cardiac activity, to ensure that the pattern of heart rate is suggestive of a healthy fetus. All this can be certainly done in a very on a regular basis at centers throughout the cities of the world. So it is possible to have a pregnancy, overcome early difficulties, and move on into a progressing process that can lead you to a third trimester situation. Now, during the third trimester, meaning the last 3 months or the last 12 weeks of the pregnancy, one needs to be very careful, because there could be an increased risk of separation of the placenta, which we call an abruptio placentae, from the wall if there is much interference of the fibroid with the wall of the uterus. There may be issues of growth, that perhaps if the placenta is not functioning at the 100% capacity because of the presence of the multiple fibroid, there could be issues of growth of the fetus. And today, with our ultrasonographic techniques, we are able to measure the fetal body and deduct what a weight is supposed to be. If the
Doc, let me ask you a
weight,
quick question. What is the
yes,
cause of fibroid, though?
say it again.
What is the cause, or what are the causes of fibroid? What causes fibroid?
Right. Well, let's say that it is mostly, one can say, the presence of fibroid is more genetic.
Okay.
Okay, it's more genetic. In other words, there is nothing that you do that make a fibroid start. It's just part of life in a given family, in a given person. And that's the reason why there is a difference in terms of the prevalence of the condition in women of different races. We know that in the African American population, up to 30% of women would have fibroids. 25 to 30%, that's what one is able to see in the literature, as opposed to the counterpart, Caucasian, it would be more in the 7 to 10%. So we talk about 3 times more fibroids in the African American, in the African population than in the Caucasian, in the white population. So even though it is considered to be a congenital predisposition and the presence of small fibroid, even in the uterus of the young girl, it takes the reproductive age for those fibroid to grow. And so it is definitely hormonal dependent. The presence of menstrual cycle hormones, whether we're talking about the estrogen, especially the estrogen and progesterone, there is a tendency for those fibroid to respond to the presence of the female hormones, the estrogen, the progesterone, especially the estrogens, that will cause the fibroid to grow. Women with fibroid and some contraceptives, hormonal contraceptive, can see their fibroid growing faster while they're on those contraceptives, especially those that are estrogen-containing variety.
Well, Doc, I have 2 questions for you, not to
Yes.
cut you off. I had a personal experience where this woman was 28 years old and she had this fibroid. She went to a doctor. Of course, they confirmed that she had all these fibroids, but the doctor told her that she should have an hysterectomy. I mean, we're talking about a woman who's 28 years old. What would be your advice to young women in their 20s who are dealing with fibroid, especially in the African American community? I've met scores of women who talk to me about fibroid issues. So what would be your advice? I mean, I don't know what it is. You're the expert. Tell us, what would you say to a 25-year-old Black woman who's experiencing fibroid?
Well, one has to sit with the patient and look at the goals that this woman has for her life. I think it really depends on whether we're talking about a young woman or a mature woman who has not had the experience of childbearing and who is looking for forward to that possibility, and someone who have had several children, has completed her childbearing goals, and is asking for it. So you can be conservative and be expectant in a way in terms of watching the evolution, if any, of those fibroid. We have at our disposal the tools to do that. If somebody does not want to have surgery and is able to tolerate the discomfort that it might, the tumors may give, one can monitor if that's the will of the patient. But in more cases than less, one can be conservative and not offer a hysterectomy if this is somebody who is looking forward to being able to experience pregnancy and being a mother. Definitely, the hysterectomy is always available, but also a myomectomy, which is the removal of the myomas, and with the uterus being left inside for future reproduction.
Now, for women that are in their 50s, late 40s, 50s, who are dealing with fibroids and don't have any children, and it seemed to me as women get older age, the fibroid might get worse. I don't know. But what would be your advice to these women, to this group of?
Well, to the extent that the fibroids are growing, one has to be very careful that there is no transformation into cancer. The sarcoma that we talked about earlier. And luckily, with the imaging technology that's available today, with ultrasound and MRI, one is able to closely scrutinize the appearance of a fibroid and see whether within the tumor there may be some signs of degeneration, which may suggest the presence of sarcoma or cancerous change. So, and normally one has to be conscious of that, and the patient needs to know that there is always that risk. And the final diagnosis is really histologic. That means a doctor may not be able to tell you 100% that this change I see there, okay, this is a cancerous. But if you have the tumor removed and the fibroid or the uterus removed, and the specimen is sent to a pathologist, a specialist that look at on the microscope, they'll be able to tell you. So there's always that as a threat to be aware of in being conservative, in avoiding surgery. You need also to stay close to the medical community that is competent to make that difference between a benign and a malignant progression. I would like also to say that since the subject is pregnancy and fibroid, at the end of the pregnancy, issues of deliveries come up. Is it a situation where I can expect to have a normal process of labor and vaginal delivery, or whether it should be that I have a cesarean section for my delivery? And I think there is no general rule that would cover everyone. Okay, it all depends on the position and the size of the fibroid. There are fibroids that are so low in the uterus that they occupy the space for the fetus to pass through. So there is no way you would be expecting to have a successful effort at vaginal delivery under those circumstances. On the other hand, there could be fibroids that are at the upper part of the uterus that may even be growing outside of the cavity, and that may not necessarily interfere with the process of labor and delivery. So every case needs to be looked at individually. And assuming a normal delivery, or assuming a delivery altogether, whether it's by C-section or vaginal delivery, the postpartum period, as far as the uterus is concerned, is a very important period to be looking at, especially in someone who has delivered a baby, okay, and now the uterus is expected to contract. Let me say that the normal process of uterine contraction is one way of preventing the woman from bleeding seriously after a birth. The uterus now that had the placenta attached to its wall internally, it finds that raw surface ready to just bleed. But luckily, nature has provided the uterus with the ability to contract. And the contraction of the uterus, even after the delivery, will squeeze that space and close the opening that would bleed normally. And so that's the way it happens. Now you can immediately see that in the presence of fibroid, that process of contracting down is impinged upon. is made more difficult. It may not happen. And if it doesn't happen, there's going to be an increased risk of continued bleeding and bleeding, which can be dangerous to the life of the woman. And so that means more monitoring, use of medication that will help the uterus contract, use of procedures that would make that likely to be treated and avoid a catastrophic event. So yeah, okay, occasionally even a hysterectomy may be necessary to save the life of the woman after such delivery.
So, in other words, because so many of our women in the African American community deals with fibroid, this is something that do you feel that we need more education because there are women who don't know how fibroid would affect pregnancy or why they're not getting pregnant when they try to get pregnant? That's one issue. The other issue is we know, as a matter of fact, and statistics are there, that Black women get some of the worst medical care. I can't say this enough, but there've been studies done where Black women are kind of the bottom, like they got the worst care. Like doctors don't listen to them, the doctors don't pay attention to them. So as far as the first question is concerned, in terms of education, I mean, you're a professor, what do you think we can do? That's the first question. The second question is, what questions can a woman who goes to a doctor, what can she insist on? What can she ask the doctor in search of getting better medical care?
Right. No, I think communication is key. Communication is key, and that means that woman needs to establish a relationship with a team of doctors who are caring for gynecologic situations such as this, and ask the key question about a prognosis. That is, what to expect in the future from what I have, because you can take three women with fibroids, and they have three different causes of action that can be taken to take care of them, because they're not necessarily identical in terms of the location of the fibroid, the number of them, or even the sizes of them. So the message is that one woman's fibroid is not equal to the next woman's fibroid. You need to be cognizant of the difference between the condition in different persons, and therefore learn to know about yourself, about your case, and be close to physicians who are competent in giving you the right information. In general, one can keep in mind that reproductive ability can be preserved, okay, unless you're dealing with a situation of life-threatening bleeding, which can happen to some women depending on the location of the fibroids. They may require myomectomies, which is removal of those fibroids in order to alleviate their symptoms of pressure and pain, if that's present, and also to decrease the amount of blood that comes out of the menstrual cycle on a monthly basis.
Okay. One more question, Doug, before we end this segment. For women that are at that age where they at 48, 49, they want to have a child, they don't have any children, and they are suffering from fibroid, would you recommend other type of ways to get pregnant if they can't get pregnant naturally?
Well, there is a question. Once you reach that age bracket, with or without fibroid, there are issues.
Mm-hmm.
Because one has to keep in mind the fact that the health of the ova, the eggs that are released and have to be fertilized in a woman's body, the quality of these eggs varies with advancing maternal age. So the risk of carrying a fetus with a chromosomal abnormality increases. So one has to be very careful in knowing that this is another added concern of great importance, and IVF, in vitro fertilization, which sometimes using donor, which would give their eggs, and donors that are younger, much younger women in the early 20s. They volunteer to donate their ova, their eggs, so to say, and so a woman with fibroids, and which is at this age bracket that you're talking about, can certainly see an infertility specialist who is proficient in IVF, in vitro fertilization, can work with such a woman, such a couple in a program for in vitro fertilization and transfer of the embryo into the uterus, and with good potential for success and continuation of pregnancy.
Wow, that's perfect. That's good. Dr. Faustin, thank you so much for your expertise. You've clarified a lot for me. I think a lot of our viewers are going to enjoy that information. You put it in terms that is, I'm not a doctor and I understand exactly what you are talking about. So I think it's the same for all my viewers. I'll give you the last word before we end this segment.
Well, thank you. Thank you for having invited me. And I think the opportunity here to let the viewers know that there is hope if you have a diagnosis of uterine fibroid. It may not be as bad as it sounds, but you need to know your case and have your doctor explain to you what the situation, what the options are, and if you're thinking of childbearing capacity, time may be of essence, and don't leave it up to many years later. So if it can be done, the sooner the better. It's been a pleasure.
Thank you, Doc. Thank you so much. Thank you.